Alright, so this is just going to be a quick review of the study guide for Exam 4. So Exam 4 covers our lectures on drug use, on psychotic disorders, on personality disorders, and on disorders of childhood. So kind of briefly hitting the highlights on some of these issues, we talked about how there are different definitions of a drug, but basically a drug is something that we take into our body that has an effect on our psychological functioning or our physical functioning. The particular definition that we're working with this textbook says that that substance is not food, so would not include food. But as a substance, using that term substance, it would also include things like over-the-counter medication, alcohol, nicotine, caffeine, that kind of thing. So we would consider a diagnosis of a substance use disorder when a person has two or more of the symptoms that are listed in the slides as the criteria. Now, it only requires two symptoms, so a person who had two symptoms would have a mild substance use disorder. And then as the number of symptoms increases, we would say it was more moderate or severe. The symptoms really of substance use disorder basically involve a person, their life starts revolving around the substance. So spending more time and energy and money than they intended getting the substance or recovering from the substance, having dysfunction associated, so an inability to complete their family responsibilities, their work responsibilities, harm to relationships, that kind of thing. Two of the more technical symptoms listed would be tolerance and withdrawal. So tolerance is when it takes more and more of a substance to achieve the same effect that you previously had with a lower dose. Withdrawal refers to the usually painful, unpleasant side effects that a person has when they stop using a drug, because your body has gotten used to functioning with that drug. And usually the withdrawal symptoms are the opposite of the effect of the drug. So for example, if you've been taking a drug that gives you energy, then you'll feel very tired as part of the withdrawal symptoms. Now, we talked primarily about two classes of drugs, depressant drugs and stimulant drugs. Depressant drugs work by slowing down the central nervous system, slowing down the firing of the neurons, whereas stimulant drugs worked by increasing the firing of the neurons, speeding up the central nervous system. So the two depressant drugs that we talked about most would be alcohol and opioids. So we talked about how these are both depressants, so they both slow down the central nervous system. Alcohol would do that primarily by working on GABA, whereas opioids would do that by producing an endorphin-like effect. So your endorphins are your body's natural painkillers, but opioids mimic endorphins and create a less natural form of pain relief. So we talked about how when it comes to alcohol, there are gender differences. Part of this has to do with your body composition, as far as how much a person weighs, as far as what percentage they have of muscle versus fat, but also the fact that women have less of an enzyme that breaks down alcohol, and therefore alcohol stays in the woman's system longer. So all things being equal, a woman will see greater effects from alcohol than a man will. We talked about how the effects that you have are primarily based off of your blood alcohol concentration, and that as a person becomes tolerant to the effects of alcohol, the person may not feel the symptoms, so they may not be aware of how high their blood alcohol content is, but at a certain point you are intoxicated, you are not able to function. Beyond that point, you start having maybe some blackouts, could go into a coma, and could potentially die, although your body works really hard to try to remove that substance from itself before you get to that point. So because you take alcohol in orally, you consume alcohol, it has to go through your digestive system. So because of that, it's not an exact science as far as how much you drink and how it impacts you. It depends on what's in your stomach, that kind of thing. It will be eventually metabolized by your liver. The withdrawal symptoms are going to be the opposite of the effects of the drug. So a lot of the withdrawal symptoms associated with alcohol are basically an unpleasant increase in the rate of firing in your central nervous system, which could make a person jittery, can make it hard to sleep, could also potentially cause seizures, so it is possible to die from an alcohol withdrawal. And then we talked about fetal alcohol syndrome. If there is a test question, as far as I am concerned, and as far as the research is concerned, the answer is 0 as far as the safe amount of alcohol for a woman to consume while pregnant or breastfeeding. Don't get that test question wrong. There's no amount of alcohol that we can prove is safe during pregnancy and breastfeeding. All right. Opioids, as we said, they're depressants. They work by mimicking endorphins. There are several different ways to get opioids into your system. So we talked about how injecting something directly into your veins is the fastest route of administration, and so therefore it's extremely reinforcing and addictive. Also, huffing, breathing in, sniffing, snorting a substance is also a pretty quick way to get it in, and so that makes these drugs especially addictive. So heroin is dangerous because, first of all, there's a danger of overdose because, especially when you inject something, you can't get it back out. If you consume something and then change your mind, or your body doesn't respond well, you can vomit it back up, at least to a certain extent. But if you inject something into your veins, you can't get that back out. There's also the risk of passing infection with dirty needles. Also, you don't know what your user has put into your heroin or whatever drugs that you have. There's no FDA approval making sure that there's only safe, I say that as if heroin is safe, but making sure that there's not any other unsafe products in the drug. All right, so stimulant drugs that increase the central nervous system firing. We talked primarily about cocaine and caffeine. So cocaine works primarily on dopamine, but also on serotonin and norepinephrine as well, which actually the neurotransmitters are very similar between cocaine and caffeine. The difference is the potency. So cocaine is going to increase the neurotransmitters by a substantial amount, whereas caffeine would only mildly increase those neurotransmitters. So we talked about the dangers of using cocaine. Really, when you use any kind of substance, there's always going to be dangers associated with that. When you're using a substance that has stimulant effects, you may have some heart-related cardiovascular or health issues involved. You're going to be increasing your pulse. You're going to be increasing your blood pressure. A person may, at certain levels here, have psychotic episodes associated with cocaine use because it does increase the dopamine substantially. And also we see dangers using this substance during pregnancy. As far as caffeine is concerned, it's one of the most commonly consumed substances. Most people get it through coffee, but you can also obviously get it through over-the-counter medications, soft drinks, tea, that kind of thing, energy drinks. One thing to say here is that it is not safe to consume alcohol and caffeine together and think that the caffeine will somehow block the effects of the alcohol. That's not the case at all. But we do see that because so many people use caffeine, many of us are familiar with the withdrawal symptoms of caffeine. A person feels tired, feels sluggish, may have difficulty sleeping, but still when you're awake, not really feel like you're energized. This can make it hard to concentrate, make it hard to pay attention, that kind of thing. Now, when we're talking about cannabis, we're talking about using marijuana and related products. Cannabis is very difficult to classify because it does produce some relaxing depressant effects, as well as some energizing stimulant effects, as well as some hallucinogenic effects. So at certain levels, a person may start having some even potentially psychotic-like symptoms, hallucinations, paranoid delusions, that kind of thing. Previously, we thought that marijuana was not habit-forming, but research has proven otherwise, and perhaps part of that is because the marijuana that is being consumed today is more potent than the marijuana that was previously consumed. It is a potentially psychological dependence where a person feels like they can't function psychologically. The anxiety and the depression and the social issues that come when a person is trying to withdraw may be more severe than actual physical withdrawal symptoms with marijuana. All right. Cross-tolerance happens when you become tolerant to one drug and therefore become tolerant to other drugs that are similar, even if you've never used them. I gave the example of how you can consume alcohol in large amounts and become tolerant to anesthesia-related drugs, even if you've never had anesthesia before, because they're very similar to each other. We talked about synergism, about combining drugs together, about how if you take two drugs of the same class at the same time, it's not an addition of, for example, alcohol plus opioids. It's more of a multiplication, alcohol times opioids, and makes it much easier to overdose. All right. We talked primarily about two potential causes and treatments for substance use problems. The behavioral treatment, there is some evidence that there's a genetic component. A person may have a genetic predisposition towards substance use. And we talked about how you can treat substance use with medications, about how you can give medications that block the effect of the drug, or about how you could give medications that reduce withdrawal symptoms. So, for example, giving methadone to someone who is addicted to heroin, or giving benzodiazepines to a person who is withdrawing from alcohol, that kind of thing. But we also said there's a behavioral aspect here where the use of the drug is reinforcing, and then when you stop using the drug, that's punishing. And so because of that, that creates a cycle of addiction. And the route of administration is important here. When you get it into your system faster, that high is more reinforcing than if you get it a little bit slower through your digestive system. All right. Moving on to schizophrenia, we talked about how psychotic episodes happen when a person is out of touch with reality. Primarily, this lecture focused on schizophrenia. You can have psychotic symptoms from, as we've said, substance use or potentially a brain injury, that kind of thing. But usually we're talking about schizophrenia, which has a prevalence rate of about 1%, about 1 in 100. And we see that individuals who are living in poverty are more likely to have symptoms of schizophrenia. But then there's also the debate over whether the stress of living in poverty caused the symptoms or whether the symptoms caused an individual to be in poverty because they were not able to maybe, for example, have a job or to function in an academic setting, that kind of thing. We talked specifically, I want to mention the relationship status here. When we're talking about schizophrenia, we talked about how individuals who are divorced or separated are much more likely to have symptoms of schizophrenia. But what I want to make sure that you've heard is that this is correlational, and it is possible that the symptoms of schizophrenia caused the relationship to fail. It's also possible that the relationship failing and the stress of that caused the symptoms of schizophrenia. But because I can't randomly assign you to having a certain level of relationship satisfaction, we can't do experiments here, so just correlational. Positive symptoms happen when you're adding something that is a psychological excess or something that we have too much of. So delusion would be a belief that does not seem to be in touch with reality. Hallucination would be a sensory experience that's not actually rooted in anything that's causing that. So hearing something even though there's nothing there, seeing something, feeling something when there's nothing there. And we did say that the auditory hallucinations were the most common. You may also have issues related to speech, so it's very hard to have a conversation with this person. But in addition to that, we might also have negative symptoms where a person is lacking something that we would expect, something like motivation, enjoyment in life. So anhedonia can also be a symptom of schizophrenia, as well as mood disorders. A person may not speak at all, or if a person does, the content of their speech may be very little. And we often see flat affect, which is just emotions that don't fluctuate based on situations that would normally cause emotional fluctuations. In addition to that, we can have some psychomotor symptoms. And a person's motor symptoms are closely tied to dopamine-related issues. So we know that dopamine is important for schizophrenia. So a person might have some, for example, catatonia, where the individual is in some odd positions or seems to not move for substantial periods of time, that kind of thing. You may also, I don't know if we talked about this in the lecture video, but the antipsychotic medications that we give to treat schizophrenia can also cause some movement-related side effects as well. All right, typically what happens is that the symptoms of schizophrenia start maybe during that emerging adulthood time period, and a person usually goes through a period of mild symptoms that maybe are missed. People maybe explain them away or don't pay attention to them, and then move into an active phase where the symptoms become more severe. And then oftentimes there's kind of a return to those milder symptoms or that functioning that the person had before. And an individual may just go through this cycle once or may go through the cycle multiple times. We do see that there is a genetic component here, as we find a genetic component with many of the disorders we've talked about this semester. But one of the issues always when we're talking about genetic components is it nature, is it nurture? The people that gave you your genetics oftentimes are also the people that raised you, people you spend time around, so that makes that kind of research complicated. Basically, the dopamine hypothesis suggests that a person has excessive dopamine or the dopamine is excessively active, and that's what's causing the symptoms. This theory is based on the fact that medication that reduces the impact of dopamine tends to also reduce the symptoms of schizophrenia, especially the positive symptoms, so things like the delusions and the hallucinations. And also there are some autopsy reports that are relatively consistent with that as well. So when we're talking about autopsy, we're talking about looking at an individual's brain structure. So with someone who has schizophrenia, you may see some changes in frontal lobe, temporal lobe, enlarged ventricles, that kind of thing. We briefly touched on a viral theory, the idea that perhaps there is a risk factor with women being exposed to certain viruses, in particular influenza, during pregnancy. And so this theory is kind of circumstantial based on the fact that individuals who are born in the winter are much more likely to have schizophrenia. But obviously this is an issue that needs further research, and it's not the sole cause, but could potentially be part of a predisposition that a person might inherit. Not everyone who is born in the winter has symptoms of schizophrenia. All right. Where do these symptoms come from? Briefly, we don't know. The best theory we have is our dopamine theory. It's the one we have the most research for. The behaviorist theory, as always, is the idea that somehow these odd behaviors have been reinforced, or socially appropriate behaviors have been punished or just not reinforced. The cognitive theory here might be that a person has some of these symptoms because of a biological reason, but then when they try to seek help, people don't believe them, people don't seem to understand them, and then that fuels the paranoia and the delusions, and then makes it more difficult for that person to reach out and get help later, which can make symptoms worse. And sociocultural would focus on stress, so poverty would probably come back up here. Are there social conditions that are perhaps causing a level of stress that triggers these symptoms in people who have a predisposition for them? Okay. We talked about personality disorders. We said that your personality is something that is unique to you and is a combination of both consistency and flexibility for the typical person, but that a person who has a personality disorder is less likely to have that flexibility in their personality. So we said that personality disorders have to be diagnosed in adults. We don't diagnose them during childhood. The symptoms have to be relatively pervasive, so across several different parts of your life, as well as having a pattern that lasts for a strong period of time. In addition to that, we look for specific personality disorders. So we don't just label a person as having a personality disorder. Our current DSM-5 gives them a specific diagnosis, and we talked about 10 in particular. And we're going to come back and talk about those in a second. However, DSM-5 also suggested, though, that it is possible that the best way to diagnose, and how we may do this in the future, is to have a personality disorder trait specified, where you give someone the diagnosis of personality disorder and then you list the traits that seem to be causing dysfunction. The thought is that individuals who meet criteria for one of these disorders often are having symptoms of another disorder, but if they don't meet criteria for both disorders, then the symptoms of the other disorder may go untreated or just ignored, basically. So perhaps it's more accurate, instead of trying to force these disorders into a neat little box, having a kind of general diagnosis that would then allow us to list the specific problems. But for the time being, we have these 10 personality diagnoses. So the odd behavior cluster, or cluster A disorders, are disorders that seem to mimic in some ways psychotic symptoms. So we talked about paranoid personality disorder, just like it sounds. A person has a very difficult time trusting other people. And one thing with these disorders is that although the symptoms are similar to schizophrenia, they're usually less severe than the symptoms a person would have during an active psychotic episode, but they are longer lasting. So a person who has schizophrenia might have an episode of severe symptoms and then go back to having milder symptoms, versus a person who has one of these personality disorders would have milder symptoms kind of all the time. So paranoia, obviously involved in paranoid personality disorder. Schizotypal personality disorder is the kind of odd behaviors, magical thinking that is strange, combined with a social withdrawal that you see oftentimes with schizophrenia as well. But when the social withdrawal becomes severe, that's where we would start looking at a schizoid personality. So this is a person who has very little or no interest at all in relationships with other people, just genuinely prefers to be left alone. Now, the dramatic cluster here has received a lot of research. These disorders may be a little bit more common than the other personality disorders. These would be your cluster B personality diagnoses. So antisocial personality is the individual who has a blatant disregard for the rights of others. So we talked about the connection between antisocial personality and conduct disorder. So an individual who has conduct disorder as a child or a teenager, about 50% of the time will go on to develop antisocial personality disorder as an adult, but we would not diagnose antisocial personality disorder in a child. That would be inappropriate. But sometimes conduct disorder does progress into an antisocial personality. And this would be the individuals that have a pattern of blatantly criminal behavior, of harming other people, combined with a lack of empathy for others. Borderline personality disorder is an individual that is unstable in a lot of ways. So mood usually has dramatic shifts. Their self-esteem can have dramatic shifts. Borderline personality is associated with an increased risk for self-harm and other dangerous behaviors. So this could be unsafe sex, this could be substance use, but it could also be suicidal ideation and attempts. We talked about how individuals who have borderline personality disorder often have a strong fear of abandonment. Histrionic personality disorder is the person who is so vain, the person who is obsessed with the praise and admiration of another person. We talked about how this could be linked to our culture today, that perhaps we are creating this a little bit with our social media culture. But a person who has histrionic personality disorder is someone who will do anything to one-up the next person, to get the attention, to stay in the light. All right. And then narcissistic personality disorder is a combination of excessive self-esteem combined with a lack of empathy for other people. So we talked about the myth of Narcissus, who fell in love with his reflection in a pool of water and died because he refused to leave. Of course, that's a myth, but you can see some pretty significant dysfunction in individuals who have narcissistic personality disorder. Basically, they view other people as objects to be used for their own pleasure. They have very little sense of the perspective of another person, understanding how their actions impact other people, and are just generally very difficult people to be around. All right, and then cluster C, or your anxious cluster, These are the individuals who probably benefit most from therapy. Therapy is very difficult with personality disorders. Usually takes a long period of time, but the anxious cluster tends to do a little bit better with therapy than the other two clusters. Avoidant personality disorder is a severe social anxiety, not just in public settings, but in personal settings as well. This is a person who probably wants to have relationships with other people, but is too afraid and anxious to be able to do that well. We can also have a dependent personality. These are individuals who basically feel like they are helpless and they cannot function if they don't have another person taking care of them. So you can imagine that it would produce a lot of anxiety if you feel like your entire life is tied up in another person. Then it would be easy to start wondering, what if this person leaves me? What if this person dies? What if this relationship changes? So this is a person who has difficulty making decisions. This is a person who always looks to another person to care for them, so they feel probably very scared by the idea of independence. And then obsessive compulsive personality disorder is just a pattern of being rigid, a pattern of being extremely perfectionistic. Sometimes this person would have extreme morals, maybe excessive morality there. A person who feels also like there's not anything wrong with them. So oftentimes people who have OCPD, they may bristle at even the suggestion that they need to do something differently because they think that the way that they do things is the only right way to do things. But just a very rigid, controlling kind of person. All right. We already talked about how we could switch to personality disorder trait specified. When we talk about the 5-factor theory of personality, research suggests, based on a lot of complicated statistical work, that there are 5 main personality traits and that each person would be high or low on these. So your personality is made up of where you fall on 5 different traits, and the acronym is OCEAN. So openness to experience, openness to experience, conscientiousness, extroversion, agreeableness, and neuroticism. Now keep in mind that neuroticism or neurotic refers to a person's emotional stability. So a person who is high on neuroticism is a person who might be extremely angry or extremely anxious, just a person who has a difficult time controlling emotions. All right. And then our last lecture was on childhood and adolescence. So we talked about how this is a time period where there are a lot of social stressors, a lot of stress about the future, combined with a lot of biological changes. There may be stress at school, stress at home, and so it's not uncommon to see children have some issues like bedwetting or worry, that kind of thing. But oftentimes those symptoms kind of go away once a particularly traumatic, difficult time period passes. But sometimes a child might need therapy. We talked about separation anxiety as an individual that has excessive anxiety about being separated from a caregiver. This is not your, few tears on the first day of kindergarten. This is over a period of weeks and months. This person continues to be afraid because oftentimes they're worried something bad will happen to them or to their parent or caregiver while they are separated. We talked about mood disorders in children, about how it is possible for depression to be diagnosed in very young children. It's much more common in adolescents than it is in young children, but it is possible, and adult medications can be prescribed to children at a young age. Bipolar disorder is one that we said in particular is problematic because it's potentially being overdiagnosed in children. The concern is that any child that's having mood issues, maybe having anger issues, that kind of thing, might be improperly labeled as having bipolar disorder and then given antipsychotic medication, which is sometimes used to treat bipolar disorder and is being given more and more to children these days. Or they might end up on a mood stabilizer. So in order to try to correct this problem, they came up with a new category of a disruptive mood dysregulation disorder, which is primarily characterized by just bursts of temper and anger that are not appropriate based on the age of the person and the situation. So behavioral disorders, we talked about how, not always, but sometimes this happens in a linear fashion where you start off with the milder oppositional defiant disorder, which is the child that is obnoxious, the child that is not obedient to parents, the child that lies, or just doesn't play by the rules, that kind of thing. If oppositional defiant disorder is not appropriately handled, sometimes this can lead into conduct disorder. It is also possible that a child could have conduct disorder kind of out of the gate instead of having oppositional defiant disorder. But conduct disorder is more severe in that the behaviors that happen here tend to more towards the criminal side of things. So we're talking about arson, we're talking about physically harming animals, physically harming people, running away from home, that kind of thing. And that conduct disorder, about 50% of the time, goes on to develop into antisocial personality disorder as adults. So we talked about how some of the treatments here might be parent management training, might be one-on-one therapy with the child. We talked about things like coping power that try to teach children how to make good decisions and how to handle emotions, that kind of thing. We talked about elimination disorders as enuresis and encapresis. So enuresis involves bladder accidents and capresis involves defecating on oneself. And that these have to be diagnosed in children that are 5 years of age or older, because at a younger age you would expect that potty training accidents would still happen. Oftentimes children do kind of grow out of these on their own, but there are things you can do behaviorally to try to treat those. With ADHD, we said that ADHD is the appropriate term, so attention deficit hyperactivity disorder. And then we talked about how it could have different presentations. So you could have the ADHD primarily inattentive presentation. You could have the primarily hyperactive or impulsive presentation. Or if a person meets criteria for both of those, you could have ADHD with a combined presentation, so both inattentive and hyperactive and impulsive. So there are other associated risks. So this would potentially cause some behavioral problems, some academic problems, maybe some relational problems if it's not handled appropriately. So we have different theories about where ADHD comes from. Oftentimes it is thought of as being a biological issue. There is a genetic component. There may be a dopamine related issue here. ADHD could also be potentially caused or worsened by the environment that the child is in. So the treatments oftentimes involve a stimulant medication. Ritalin is one of the most common, but Adderall and others are possible. The difficulty with these medications is that they do have side effects. They can negatively impact growth. They can reduce a child's kind of cognitive abilities. But then, of course, there's the concern about leaving ADHD untreated and then having those associated learning issues, academic issues, that kind of thing. So in addition to drugs, there is also behavioral treatments that oftentimes involve making accommodations for the person that has ADHD, a quiet place to take tests, having someone repeat the instructions to them, simplify the instructions, that kind of thing. A lot of really positive reinforcement for appropriate on-task behavior would be helpful as well. As far as multicultural factors go, we talked about how children of minority groups might be less likely to receive the assessment that they need if an individual does have ADHD, and then also maybe less likely to receive appropriate treatment, and that's often linked to financial issues in school districts. All right, autism spectrum disorder. We talked about how the core symptoms include communication issues, social issues, and then often some repetitive behaviors or just really limited interests. So the person may have very few things that they enjoy doing, but they enjoy them quite a bit and make it very upset if they're interrupted. So we have seen a pretty significant change in the way the DSM conceptualizes autism. Instead of having different possible diagnoses, they're all combined now into an autism spectrum disorder diagnosis, whereas previously we had autistic disorder as well as Asperger's disorder or Asperger's syndrome. So now with that combination, someone who previously would have been diagnosed with Asperger's syndrome would now be given probably an autism spectrum disorder mild diagnosis. Possible causes, there does seem to be a strong genetic factor here. So oftentimes we think of this as something that is biological in nature. A couple of things to bear in mind. One is that there is a lot of controversy regarding vaccines, but not a lot of good research supporting the causal relationship between vaccines and autism. And also, one other thing I mentioned in the lecture video is that oftentimes we might start to say, okay, well, maybe there's just some family dysfunction going on, but research does not seem to suggest that family dysfunction causes symptoms of autism spectrum disorder. I mean, any kind of family dysfunction could potentially make symptoms worse, but that's true for any disorder. As far as the treatments go, oftentimes we have parent management training to teach a parent how to work with a child who has autism spectrum disorder, working with teachers and other caregivers as well. A child who has autism spectrum disorder may have behavioral treatments to help them build up their communication skills and their social skills, and then giving reinforcement when they meet their goals. The last major topic we talked about was intellectual disability, about how this involves individuals whose IQ scores are 70 or below, so their score on a standardized intelligence test, combined with some deficits in adaptive functioning. And so when I talked about adaptive functioning, I was talking about a person who has difficulty with day-to-day self-care, relationships, work, school, that kind of thing. Now, there's a range, as with most disorders, a range of severity. And on the milder end, many individuals who have an intellectual disability have a mild intellectual disability because of environmental issues, things like problematic school environments or just understimulating environments at home, that kind of thing. As we have more severe symptoms, then oftentimes those cases are more biological in nature, so it could be Down syndrome, could be fetal alcohol syndrome, or any other number of other genetic concerns or issues there. But as the symptoms become more severe, a person is likely to need more supervision. A person may not be able to, at a certain level, a person may not be able to have a job or be able to handle appropriate self-care. So that's why we have a strong need for training programs for individuals who have intellectual disability to try to give them as much independence as possible. And I talked about the importance of having appropriate expectations. Expecting too much just causes frustration, but expecting too little causes a person to not meet their full potential. Alright, so this has just been a quick review of the major topics for Exam 4. So let me know if you have any questions. Otherwise, I will talk to you guys later.